Oh, let me adjust my yeah, head is cut
Yeah,
off.
me too. Hold on, let me move back a little bit.
Oh, that's how you do it.
Yeah,
It has been a while since I've
I know, right? It's so funny. I was like, oh, I thought I had everything covered.
oh, this tripod on carpet.
Yep. Hold on. I'm far away from everything. Do a little setup here.
Oh, yeah.
Give me
All right,
just.
while Dr. Qualls and I are getting our camera angles right, welcome everyone. Thanks for joining on a Wednesday evening. We hope you're all doing well. We have a handful of folks joining. There's Ola. Welcome. All right. Do you think we should give it a couple more minutes or should we jump in?
Um, Maybe like 2 minutes or so.
Sure.
Probably would be good. Give people a chance to get the alert. That's my thought
Sure.
process.
How's your day been?
Pretty good. Can't complain. A little busier on the front end, but a lot more chill toward the back end. So exactly what I needed for today. How about
Good. You're not rushing right into the live after a long day.
I know. That's always the worst. How about you?
Yeah, same. I had some work calls and such, but then, like you, I slowed down towards the end. So I
Yeah,
ate, breathed, and then came here. So
exactly. Exactly. Same here. That makes sense.
awesome. Well, thanks for everyone for joining. We'll get started.
Hmm.
I think we should get started, but with the intros, and then hopefully folks will join more.
Okay.
Thanks everyone for joining. So my name is Samira, and it's hard to describe. I guess I'm with Sexual Health for Muslims, and I'm a sexual health educator. And tonight I'm really, really honored and feel blessed to have Dr. Qualls here with us, who will be sharing a lot of her expertise, and I will let Dr. Qualls introduce herself.
Oh, well, thank you. That was a nice introduction.
Thanks.
First of all, I just want to thank you for inviting me here because I know this is a topic that, a lot of people suffer with, but they suffer in silence, so they think there's no hope. So I'm glad that, I can come and show or share my expertise in this area and hopefully help someone on their healing journey. So I'm really thankful for this opportunity. So like you mentioned, my name is Dr. Taya Qualls. And I'm a licensed physical therapist in DC, Maryland, and Virginia. And in addition to that, I am the owner of Quality Touch Physical Therapy and Wellness, which is a mobile physical therapy practice here in the DMV. And basically, all that means is that, we provide services in the comfort of your own home or private space.
That's great. And I think at a time like this where folks are isolated to their homes or they may be more at risk for traveling for services, it's great that you're offering it in their homes, which is
Yes, indeed.
wonderful.
Yep.
Awesome. So we're here for a reason, and the reason being that I've received a lot of questions from folks who are following sexual health for Muslims about pain with sex and specifically about vaginismus.
Mm-hmm.
And so we have had some questions come in, both of us, and we'll be addressing those towards the end of the evening.
Mm-hmm.
And just a little bit of a note that some of you did ask questions related to Islam and navigating Muslim myths that may exist. And if we don't get to that tonight, I'll hopefully answer them after the Instagram Live using other videos or posts. So just wanted to say we're not ignoring you. We want to completely have Dr. Qualls have most of the floor time since she's an expert and we'd love to hear from her.
Nice.
So with that being said, I think let's get into this topic of vaginismus. And I think you were mentioning a great place to start would be talking about anatomy.
Yes, and before I get into that part, I just wanted to let everyone know that we're here tonight just, providing educational insight. We are letting you guys know some information generally about this condition, but we want to make sure that you all don't substitute this for an assessment by your own personal licensed healthcare provider. So just wanted to say that before we got into it. If you think you have this condition, please consult your physician or your pelvic floor therapist and let them do a workup just to see what's going on. Okay. So now, with that said, I wanted to start off with anatomy because I know that most lay people aren't familiar with the anatomical structures. So just want to give you guys a little bit of basic, very basic. I'm not going to teach you an anatomy class here tonight. So what I have here in front of me. So this is a model of the pelvis. And essentially this is the white part is the bones of the pelvis, and the red parts you see are the muscles. I'm just going to generally go over some function with you all right now, because when we talk about vaginismus, I want you to kind of get an idea of what these muscles are responsible for, okay? So I'm going to turn the model facing this way. This is a female model. So in the front here, if you're, for instance, going to your gynecologist or your pelvic floor therapist, you will usually lie on a table at some point in your session, and they'll be looking at you from this view. So if you can kind of imagine, this is the area of your vulva, and this is what a healthcare provider will be looking at. Okay, now, so the pelvic floor, it has three layers of muscles, and these muscles all work together to produce function for your bowels, bladder, and sexual systems. So this first layer here, this will be the vulvar tissue here. And these superficial muscles here, it's about three of them: ischiocavernosus on either side, bulbocavernosus that are right outside the opening, and then the perineum, the superficial transverse perineum. Those muscles are typically some of the key ones involved in the diagnosis of vaginismus. These muscles in the front, they are really heavily involved in sexual function, right? Now, deep to these, so deeper in, there's another layer, intermediate layer, that's really responsible for a lot of the bladder function, like holding in the urine, letting the urine come out. And then there's a muscle on the inside that wraps around the opening of the vaginal opening that stabilizes that structure. And then I'm going to turn it inside the cavity here. You have all these muscles here. These muscles are largely responsible for supporting, stabilizing, and helping a lot with bowel function, as well as giving urinary function as well. So a lot of people who are familiar with the term Kegel, these muscles deep here, these are some of the prime muscles responsible for that Kegling function, okay? So I just wanted to give you that brief little basic anatomy. Now, a lot of times too, Samir and I were discussing this, people, when they refer to their genitals, particularly women or those with vaginas, they usually call this vagina. And I wanted to just let you all know that that outside portion is not the vagina actually. The vagina is the canal that is on the inside. The outside is called the vulva. That part where you see the labia tissue, or what some commonly refer to as lips, that's the vulva, okay? So I just wanted to give you that little nugget, okay? So now we're gonna jump into a little bit about vaginismus. Generally speaking, vaginismus, it's basically a condition where the pelvic floor muscles involuntarily contract in the presence of an attempt to something being inserted into the vaginal canal. That can be through intercourse, through a pelvic exam by your physician or your pelvic therapist, or it can be something like even inserting a tampon or menstrual product. So what happens is, in the presence of that, those muscles start to clamp down and they get really tight. And a lot of times it makes penetration impossible and definitely painful. So I like to just let people know that when they experience that, if they're experiencing that, that it's not your fault. It's not something you're trying to make happen. It's not something you're trying to do. It's your body's response to something that is fearful usually, as a way to protect. So just keep that in mind. I know I've heard a lot of patients say that they thought it was something that they were doing wrong, or they've gotten blamed for it, unfortunately, and that's not the case.
So I think it's really great you went over anatomy, because a lot of folks who have vaginismus who've messaged us, and I've heard in the past in sexual health work, people often forget that the vulva, the vagina, is all made out of muscle. It's not any different than a part of your body that's experiencing pain, for example, such as your shoulder or your hamstring. It's muscle. And I think because we don't often know anatomy the way that you do as a professional, it's hard to sometimes know what's going on. And so we think, well, what is it, like, where is this pain coming from? Is it in my head? So I think that anatomy is really important, that folks know that there's a lot of muscles down there, and also nerves as well. So it's complex, right? It's a very complex part of our body.
Very complex, like you said, muscles, nerves, blood vessels. So when all of these structures are intertwined and they're doing their function, usually everything's fine. But if there's some kink in the chain, if one of those systems are out of whack, then that's where you can get some of these pelvic pain conditions, such as vaginismus.
Perfect. So just want those who know to know that if you've heard that it's in your head, the pain's in your head, it's not in your head. There are actually maybe physical, neurological combination, which you're going to go over reasons why you're experiencing pain.
Yes, definitely. One thing I wanted to mention too, back to like a little definition, when it comes to vaginismus, there can be different types as well. And one of the two of the primary terms associated with vaginismus is primary and secondary. So primary vaginismus typically means that someone has never been able to successfully have penetrative vaginal intercourse or undergo a pelvic exam or insert a menstrual product. Nothing has been able to penetrate the opening. Whereas secondary vaginismus, that can occur at any point in the life cycle. Someone has been able to have penetration, but at some point or other, there's been something that impedes that. So, for instance, during the perimenopausal time of life or postmenopausal, when the hormones change, sometimes the tissues get more sensitive and painful for some odd reason. And so what happens is maybe the muscles in response to that discomfort and pain begin to get a little angry and they clamp up. So that could be just an example of a time where you've been able to, successfully have intercourse, and then all of a sudden, oh, this is not pleasant anymore.
Right. So good to know that there are two different types, and often a professional such as yourself, pelvic floor PTs, will be able to kind of get to the root cause of what's happening.
Exactly.
Perfect. So now that we've talked about what vaginismus is, could you talk a little bit about symptoms so that folks who are experiencing it could maybe be aware if they may have vaginismus?
Definitely. So typically, when we think about the symptoms associated with vaginismus, oftentimes people will say, when my partner attempts to insert the penis, I feel a burning, tearing, ripping sensation. They say terms like, it feels like there's a brick wall there that he can't go through. Or they may mention that they feel clamping up or contraction of their inner thigh muscles, for instance, their buttocks, or even their abdomen, their tummy. So those are some things that are commonly associated with vaginismus. Other things could be something that you may not even think is a symptom, but like avoidance of the activity just because of the associated pain. A lot of times people who experience vaginismus will begin to kind of separate themselves from intimacy because they don't want to even take a chance with going through that process. So those are a couple of things that I commonly hear people say or that I experience. Sometimes heavy breathing because they know that they are about to experience pain. They clench their bodies up. Those are some typical things.
So that's really helpful to know that the type of pain you describe, those sensations are quite common. So the stinging, the burning, the hitting a brick wall. I think some folks have said, I don't think my vagina is large enough for this penis to enter because it just feels like there's a complete block happening.
Exactly. That is so true. Those are common things that I see or hear. They may say things like, when I try to, because there are some people who can insert a tampon, for instance, but can't undergo penetrative intercourse. They'll say, well, when I go to insert the tampon, I don't have any problems. But when my partner tries to, have intercourse with me, then nothing can happen. So those are some things that you may see, some common traits.
That's good to know. So hopefully folks are making note of that. And if you've just joined, I see a couple more people joined. I'm with Dr. Qualls, a pelvic floor physical therapist, and we're here talking about vaginismus and painless sex. So welcome. And so a lot of times folks aren't sure where this originates from. Is it something that happened to them when, like an injury? Is this something that is common? So what are as a professional, what do you see as the causes of vaginismus?
That's a good question. A lot of times it's hard to find out the exact cause with vaginismus. However, commonly what I'll see is that a person may have physical and emotional stressors. Stress is a huge part of it. I would say 9 times out of 10, my patients with vaginismus have some level of high stress in their lives or some emotional stressors for some odd reason. Individuals who may have experienced childhood or adult sexual abuse or trauma, that can be a common contributor. Let's see. body image, how someone views their body, what they think about their body, and especially their genitals or their what they would consider their private parts. If someone is a little bit more insecure about some part of their body, especially the genital region, they may not feel as comfortable relaxing, and because of that, muscle tension is going to occur more times than not, and then vaginismus can ensue. Those are a couple of things that I think are some common contributors to this.
So that's an important list, I think. And I know there's probably individuals who have trauma is so pervasive. We know that a lot of folks experience it. So that's something to take into account. And since we are talking about faith-based and Muslim communities, a lot of what I've seen is lack of sexual health education, and then the lack of knowledge about your body. Do you sometimes see patients who come in and the fear comes from not knowing their body? Could that contribute to it as well?
Agreed, 100%. Sexual education, you hit the nail on the head. A lot of times when there are misconceptions floating around about what happens with sex or what you should or shouldn't do, people will begin to develop a sense of shame or just a sense of embarrassment about genitalia, about intimacy, about sex. And so that can definitely contribute to this as well.
So a lot of factors and complicated. And do you find that sometimes it's not like you have one specific cause where you're like, this is it, or is it more complicated?
No, more complicated than that. I usually find it as layered. I hardly ever see someone that comes in with one source of a contributor to vaginismus. Like many other conditions, there's usually some layering involved. So, for instance, I have patients who are have high-powered or high-stress jobs, and they are constantly on demand and working hard, and they could have this condition as well, just because of the nature of what they do. But when we go through their history, we may find that they are, have had some type of experience sexually that wasn't pleasant. And and let me back up for a second. It doesn't have to, when I say trauma or sexual trauma, it doesn't have to be something that you may generally hear or define it as. It could be something like someone made a negative comment about your body. It could sometimes come from family interactions as a younger person about, you shouldn't, I don't know, I can't even think of an example, but just the do's and don'ts about what you should do or not do with your own body. And so when people constantly hear those types of cues, that will translate into a physical manifestation oftentimes.
So it sounds like there's a bit of a brain pain, like a brain to body connection. Can you talk a little bit about that with vaginismus?
Definitely. So when an area of the body, even outside of vaginismus, but since we're talking about that, I'll stick to that. But when an area of the body has had pain on a consistent basis, particularly at one area, in this case, the vulva, the vaginal area, that area of the body will constantly associate that area with pain, even outside of a painful stimulus. So even when I start to treat people, sometimes we find that those initial sessions, especially, even with the gentlest touch, someone's response is usually disproportionate to what we're doing.
So it might be that you are perhaps touching a part of their vulva very gently, and yet you might find the patient bracing as if it was more of a different type of touch.
Exactly. That's the perfect example. You hit the nail on the head. Basically, usually it's like, it's like you said, it's a bracing, it's a tensioning. Sometimes I have people, I can tell they're holding their breath. And it doesn't even have to be that I'm touching the vulva tissue, because I usually, with this population, I let them steer the direction that we're going to go in. So sometimes I like to show people what gentle touch feels like, or prepare them for what my touch will feel like with my gloved hand, of course. So I may touch their thigh, their inner thigh area, just to give them a preview. And even there, if that's the first time, they, will clench up like that. So there is a brain-body connection.
And so in relation to vaginismus a little bit, there are other diagnoses that you work with in the realm of pelvic pain. Do you mind talking a bit about those, since folks did ask us about vulvodynia, for example? Hopefully I'm saying that right. So maybe touching upon that.
Yes, definitely. I'm glad you asked that. So in addition to vaginismus, and this is good because just because you have tightness or pain with intercourse doesn't mean you necessarily have vaginismus. It's because
Mm.
there are other conditions. So in addition to vaginismus, there's condition that you mentioned, vulvodynia and vestibulodynia. And all that means is pain of the vulva or pain of the vestibule. And let me show you something really quick. Back to the model again.
Mm-hmm.
I tried not to be technical, but I had to get it in
No,
there.
it's so, I think it's helpful to have a visual. How often on Instagram Live are people pulling in pelvis models and showing it?
Right.
This is so awesome, people.
Right. So this area would be considered the vestibule. That's that very initial entrance into the vaginal canal. The vulva is this entire structure. So the terms vulvodynia and vestibulodynia just means that those structures have pain. And oftentimes with those two conditions in particular, there will be an intense sensitivity to touch because the tissues are just very irritable. Oftentimes that's associated with some hormonal imbalance.
Mm.
So that's why I said if you think that there's that you possibly have vaginismus, don't just assume and start treating yourself or taking some of these tips. You need to see a physician or a pelvic therapist because your physician may want to get blood work done to look at hormone levels. They may want to do certain specific testing just to make sure that it is not vaginismus plus vulvodynia or plus vestibulodynia. You know what I mean?
Yes.
Yes. And then outside of that, there are other conditions like endometriosis, for instance, that contribute to pelvic pain. Oftentimes with endometriosis, the pain, especially with intercourse, is felt much deeper in the canal. Not that it can't be anywhere else, but that's a prime thing where people will say, oh, when my partner is inserting, I feel pain deeper into the back of my vagina or something like that. PCOS is another one. That's polycystic ovarian syndrome. And again, these are reproductive conditions and hormonal conditions. So oftentimes when the hormones are a little bit imbalanced, then we need some regulation of those to be able to have a successful course.
So a lot of additional factors to consider. And like you said, if someone's experiencing this, you don't want to be treating it by yourself.
No.
Or yeah, it's very complex, and it's really important that you seek support from a professional such as yourself.
Definitely.
So related to pain, there are some folks, and especially with Muslims, we all actually beyond Muslims, there's a lot of misunderstanding about the hymen.
Oh.
And some women will say, well, what if it's my hymen that's the issue? Like, what if it's not vaginismus, or is that vaginismus? So can you chat a little bit about what you see and know about the hymen with regards to this?
Sure. Typically, so the hymen is a structure that's covering the opening of someone who has never had, I don't want to necessarily say intercourse because the hymen can be pierced with other activities.
Yes.
Too. But typically people associate the hymen with a virgin, for instance.
Yes.
A virgin is someone who has never had intercourse, right? So when the hymen is intact, it's covering that opening. And so if it's pierced, there could be some discomfort, but we typically don't expect that pain to ensue time after time after time. Whereas with vaginismus, that's going to be more of the musculature, and it's going to occur every time or often when an attempt to insert into the vaginal canal is done. So the hymen, again, when it's intact, if someone tries to pierce it, yeah, you may have some discomfort, some intense pressure is what people typically say. But once it's pierced, we don't expect there to be much pain after that. With vaginismus, more than likely without treatment, you're going to experience pain with every attempt until such time that you have some interventions done.
All right, perfect. Thanks for clarifying that. It does. I think that's a really important clarification because it's something I've heard quite a bit, that perhaps it's my hymen, and yet this person has been experiencing pain for months on end. And so hearing that is, I think, really informative.
You just made me think of something too. With vaginismus, typically what I find as well is that once the act is stopped, so whether or not intercourse is stopped, the pelvic exam stops, or the attempt to insert a menstrual product is stopped, the pain is usually gone after that. They usually say, I only have discomfort when this is attempted or with that touch against the entrance. So usually it's not like constantly as you walk around or as you do your daily activities. That definitely is not a key factor in vaginismus. So if you're experiencing constant pain nonstop
Mm.
or intermittent pain outside of those particular activities, then you definitely want to have your physician take a look and see what's going on, or have a pelvic therapist take a look and see what's going on.
Perfect. And I am seeing that there's a question, and we actually will answer that. It's about vaginismus and dryness.
Okay.
Did you want to answer that now, or should
I
we
can answer
wait?
it now.
You can ask. Okay, so the question is there a difference between vaginismus pain versus lack of arousal that leads to dryness and pain?
Okay, so vaginismus pain versus dryness. Am I
Exactly. Yes,
okay?
vaginal dryness.
Yes. So with actually, it's interesting because I wouldn't necessarily separate the two sometimes. Now, just for a little bit of physiology, I guess, with vaginismus, again, it's dealing with the muscles. So the muscles are tight of the opening, right? With dryness, that has to do with the glands that
Hmm.
lubricate those structures. So there are glands that are around the opening and inside that are responsible for providing moisture, essentially. If those glands are impaired for some reason, or if someone's just not aroused, then the tissue will feel drier and be more shriveled and be very uncomfortable, even if a person doesn't have vaginismus. With vaginismus, on the other hand, the muscles are tight. So you're going to see that someone can be dry, have vaginal dryness, and have vaginismus, and someone can have adequate moisture and still have vaginismus.
Mm.
Does that make sense?
Yeah, so it's not necessarily correlational. It depends. You can
Mm-hmm.
have one or both.
Right.
And again, it's something that your professional would be able to note because you are examining the muscles of the pelvic
Exactly.
floor.
Right. And then the good thing, though, and some people who may be viewing, they may have had their physician say, well, make sure you use lubricant. So we want to
Hmm.
make sure you understand that even though these two conditions are different, the lubricant, even though we're trying to provide moisture to the tissues with the lubricant, the purpose for that is because with that added slippage, that can make the process a little more comfortable. So where the physician may have said get lubricant to help with your vaginismus because they want to make sure that you are able to get a little bit more slippage of the tissue. Does that make sense?
Absolutely.
Okay.
And it can help in terms of insertion because
Yes.
it's getting rid of that friction,
Yes.
really. It's helping a bit of.
Exactly.
Right. And I know you have more props, and so I know you have samples of lube that
Yes.
will show. Not
Yes.
that you're selling it, but
No, not at all. I
it's
just want to, make sure people understand what we're talking about because some people have never heard of lubricant before. They don't even know what that's
yes,
for, especially younger people. They don't tend to use a lot of lubricant. But I have a couple
yes.
of samples here. This one is Good Clean Love. I'll try
Hmm.
to bring that. And I'm not promoting any product. I don't sell any products. I don't have stake or anything. I don't have any type of stocks or anything. And this is slippery stuff. So these are examples of lubricant. Of course, when you buy it, it's going to be a bottle or something like that. It may not look like this. But basically, those are just some examples of a type of lubricant. I usually typically recommend something water-based that doesn't have a bunch of chemicals and things in them.
Hmm.
Just because if your tissues are already a little bit irritated, then if you add something that has a lot of chemical products, it could irritate the tissues even more. So you may want to use something that's a lot, I wouldn't, I guess you would say as natural as possible.
Right. And
Mm-hmm.
I know when we get to the part where you're talking about dilators, you recommend some lubes for dilators and then maybe different types for intercourse or other functions.
Yeah, I would say, and this is just a preference because of like for instance, if a patient is coming into the clinic, I typically use a slippery stuff lubricant. It's thicker for what I'm doing versus like the Good Clean Love brand is a little watery. It has a
Hmm.
little thinness to it. So sometimes that's more pleasant for intercourse for some, but I've had some patients say they prefer the slippery stuff with intercourse. So it's person dependent.
Perfect. So
Mm-hmm.
it's a matter of trial and error
Yeah,
sometimes too, because everyone's body's chemical composition is different, lubrication feels different.
yeah,
So it really
exactly.
varies. So I hope for the person that asked that question that that answer helped, and comment below if it didn't, and we'll try to get some more information.
Mm-hmm.
So we've talked a lot about vaginismus anatomy, and so let's move into what pelvic floor PT is. It's I think gained so much as it should popularity and awareness recently. So can you
Mhm.
talk a little bit about what is pelvic floor PT?
Good. I'm glad you asked. So,
Yes.
I mentioned it a little bit earlier, but basically, pelvic floor physical therapy is essentially physical therapy. We are physical therapists who specialize in the pelvic floor. So, we basically treat conditions of the bowels, bladder, and sexual systems. So, anything dealing with peeing, pooping, and having sex. So, we deal with those conditions. And so, what we do is the same thing you would experience if you went to a therapist for your shoulder, your knee, your hip. We do an assessment so that we can see what's going on with this area of the body, and we come up with a plan that's specific to your needs and
Mm.
basically try to help you improve your quality of life as it relates to those areas.
Perfect. And it's specialized in terms of you've had to go through more education and
Exactly.
specialized education than just your
Yes,
doctor of PT.
exactly. So typically you would have gone through your normal PT course. And then and some people are starting once they're in their last year of PT school
Mm.
nowadays. I've been out of school for a while, so it was a little different when I was in school. But typically, once you finish your PT course and you take your boards, you become a physical therapist. But then you have to get continual education in pelvic floor treatment, evaluation and treatment. Some people will go as far as getting a certification in the pelvic floor, the treatment of pelvic floor conditions. You usually are going to want to stay up to date with a lot of techniques and things, just like any other physical therapist. So a lot of what we would do is wrapped around the pelvic floor for all
Mm.
genders.
Right.
Mm-hmm.
Perfect. And so when somebody is seeing a pelvic floor physical therapist, what would treatment options look like for someone who's coming in, let's say for vaginismus?
Sure. Now, I want to say, I always tell people, it's not going to be a cookie cutter answer because everybody is different. Literally everybody is different.
Hmm.
So when I do an assessment, it may look different than another physical therapist, but ultimately the skeleton should look the same as far as the bare bones. So typically speaking, when a patient comes in to see me, they would have already filled out paperwork. I would have read over that paperwork, and then I will use that to ask them more questions on the initial assessment, just to fill in the blanks and figure out how things have been playing into what's going on. I get through that initial interview process, and then I go into a physical assessment. Now, a lot of people come in and they think, oh, we're going to get undressed on the table.
Hmm.
But I often like to tell them, no, we're going to go through a couple of other steps first because you're not just a pelvic floor, you're an entire person. So I actually will look at movement patterns. I want to look at how their body moves. I want to look at how their posture looks when they stand up, how their
Mm.
posture looks when they're sitting or laying down. Things like their hip mobility, because their hips are so close to that pelvis, like you saw in
Hmm.
this model here. The hips, people actually think of this part of the body as the hips, but actually
Mm.
the hip goes into this socket here. So it's, not the whole bone here. So, if their hip mobility is off, then sometimes that can impact pelvic floor function. We look at their spine, their low back is a huge contributor. So we look at the spine, we look at strength of all of those structures, we look at motion, and then I also like to look at the abdomen. The
Hmm.
abdominal structures are closely related to the pelvic floor structures as far as um, fascia. I know some people may not know what that term is. Fascia is just like a connective tissue. It looks like a spider's web essentially, and it connects us from head to toe. So I look at the abdomen and see, is anything tight in the abdomen? Is anything
Mm.
excessively loosened? I look at breathing patterns. Breath is very important. Um, and then essentially, when we're ready to transition to the pelvic floor specific portion, I like to do an external assessment of the pelvic floor. So, and I ask permission, are you prepared or are you ready to do this part? And I'll look at how the muscle tissue of the outside of the vulva feels. And then I'll do the same thing deeper into the folds near the anal area. And I'll have them do different contractions and see how
Mm.
well they're able to relax, and also see how well that they are able to even push out a little bit, right? And so once we got through that part, I'll go ahead and I'll do the internal assessment if they want to do that during the session. Just so you know, you don't have to do the internal pelvic floor assessment. We don't even have to touch your genitals
Mm.
when you come in until you're ready for that, right? Because there's so many other elements, like I mentioned before, that play into the pelvic floor that we need to be addressing the whole picture. So when a patient shows me that they're not quite ready for that, I don't push and push. I make sure that they know that it's up to them when we transition to this portion. And so if they are ready to do that, we'll do that on the first session or some subsequent sessions. Whereas with this condition, I'm not always expecting to get very far. I'm not going to probably get my finger, even a tip of my finger in, but I like to at least make the attempt if they are comfortable with that. And usually I just want to assess the quality of the tissues, see how the tissues feel. Can it contract? Can they relax? Can they bear down? And this is important too, because sometimes people don't know that they are at times actively contracting and they're tensing up actively. They don't know sometimes even how to contract their muscles or how to let them go. So we look at all of that as well. And once I get all of the pieces of the puzzle, we come up with the treatment plan. And then the treatment plan will definitely involve some level of a home exercise regimen based on what I found. A lot of times for people with vaginismus, I find that I'm going to give them some type of hip flexibility program, hip openers for the inner thigh muscles, outer thighs, hip flexors, the glutes, the trunk. You know, those muscles definitely need to be pliable and flexible because if they're tight, like I said, because of the proximity to the pelvic floor, then the pelvic floor muscles will respond accordingly as well. We're going to likely do some hands-on activities for most people. Now, I do see people virtually as well. And although it's going to be minus the manual part, there's a lot we can do through the virtual platform. But if they're in the office or if I'm at their house with them, then I'm going to do hands-on treatment. And I'm going to basically begin to release tight structures and try to get things to soften up and become more pliable in and around the pelvic floor. In session, we're going to work on breathing mechanics, like I mentioned before. And I don't know if many people understand the correlation, so I'm just going to talk about that a little bit.
Yeah.
Basically, when we're breathing, we're using our diaphragm, which is the muscle right under our rib cage. Now, our pelvic floor is right underneath at the bottom. So the rib cage, the diaphragm and the pelvic floor are mirrors of one another. So if one is restricted, the other likely is too. So when someone shows me that they're a really shallow breather, for instance, I like to make sure we work on breathing mechanics, because we want to make sure that when they take that big belly breath in, which can provide a stretch to the pelvic floor, that they're getting a full excursion. Okay, so we'll work on that breath work. We may even do some things, and let me make sure you understand, we may not do all of this in every session. I'm just telling you a general laundry list of things that could take place. We do this when it's appropriate based on what we're seeing from session to session. So oftentimes I will, work on one or two of those things throughout the session, because bodies are temperamental. They do what they want to do, right? They don't always respond quickly. A lot of these techniques take, minutes, not seconds, right? So with biofeedback, we'll do biofeedback. And biofeedback just means that you're receiving an external stimulus to produce an action, right? So for the muscles, for this case, we're trying to get the muscles to relax more. So it's called down training. And we're wanting the muscles to relax. So we'll use sometimes a visual apparatus that has a dial on it or some type of signal to the patient. Hey, you see this dial? We want this dial to go down. Use your muscles, and we would have shown them what to do or told them what to do, but use your muscles to make that dial go down. And this is a way of getting them to be more aware of what their muscles are doing or capable of, and also ultimately to get those muscles to relax and let that be more of their baseline, right? In addition, let me see what else. Biofeedback, manual therapy. We obviously are going to do some exercises. Yes. When I mentioned the trunk and the hips earlier, the trunk and hips are very important when it comes to pelvic floor. When people think of the core, they always think of the muscles in the front, the six-pack muscles. But your core actually is your whole trunk, that whole cylinder, right? So that's your abdominal muscles, your back, your obliques, your pelvic floor, and your diaphragm. So if this trunk musculature is off, and if these hip muscles are off, meaning they're weak for some reason, if they lack coordination, if they lack power, if they lack endurance, then guess what? Those smaller pelvic floor muscles are going to try to tighten up and take up the brunt for what these larger muscles aren't quite doing. So we have to sometimes do a strengthening program in conjunction with everything for these other muscle groups as well. And a lot of desensitization. Desensitization. And the reason why that's important is because when someone comes in and they've been experiencing pain for so long, they are not going to just be like, okay, I'm just going to let you do whatever. They will often need to slowly be shown that this is a safe touch, or
Right.
how to get the tissues to relearn what's safe and what's not safe. So I'll teach them techniques that they can do on themselves, because sometimes
Mm.
they're not comfortable with me touching in a certain area of their body. But if they are, I'll show them with my touch as well. And then we slowly get that area to understand, oh, this isn't danger. This is not something that we need to be afraid of, right? I'm trying to think, is there anything else I missed? I think that's all, a pretty good laundry list right there. There's other things you can do as well, but those are some key things that I might do with the patient.
And like you said, it's there's you have a ton of different tools in your
Right,
toolbox. And
right,
so depending on the patient,
right.
depending on perhaps how they're coming in the following session, you're drawing on all of these to kind of gauge where they're at and then help them progress. And you're also, as you mentioned, you're giving them a home program that they
Mm-hmm.
will do, both
Yeah.
physically perhaps, but I really appreciate you bringing up breath, because I think the brain-body connection with vaginismus
Mm-hmm.
and pelvic pain, and just myself as a yoga instructor, when I'm instructing how to breathe, it's that same diaphragmatic breath that
Yes.
you would coach, I'm pretty sure, in terms of being able to expand your belly and then
Yes.
also relax your pelvic floor as you breathe. It's great to hear that it's helpful in terms of dealing and working through pelvic pain.
Yes. And you made me think of something else. Mindfulness is a huge part of
Mm,
some people's journey as well. And the reason why I say that is because, for those that don't know what mindfulness is, it's basically techniques that are used to help calm down the fight or flight responses of our bodies. When people have had pain for a long time, or just maybe anxious or high strung, or whatever the case may be, their fight or flight systems are, their nervous system is really revved up, right?
hmm.
So mindfulness can be a huge help in helping their musculature generally in their whole body, but especially their pelvic floor, to calm down. So I'll often recommend that they do some type of mindfulness routine that works for them. It does not have to be, because some people aren't good with meditation. I know I'm not.
Hmm.
So it doesn't have to be meditation. It could be like taking a slow stroll in a
Yes.
nice serene area. It can be journaling. It could be
Hmm.
listening to calming music, something that's
Yes.
mindful for you specifically, not just what you see other people doing. And so with that, the mindfulness piece is helpful, because when your fight or flight system begins to calm down and understand that you're not getting chased by a tiger, then the musculature responds better too. So that's a huge part of it as well.
Yes, and knowing that this all works in combination, and so you're addressing all of this and helping the patient also understand how it's working in their body,
Yes,
and for them
definitely.
to be educated.
Definitely.
So in terms of finding a pelvic floor PT, how would somebody go about finding a professional?
Definitely. There's a couple of resources. I love to use directories when I'm referring to my patient, having my patients refer to um, either other practitioners, or if they're moving out of state, or even people will email me. So one great directory is by Herman and Wallace, Pelvic Rehab Institute. They have a directory, and we can put that link in the, oh, you already did it.
Yes.
Yes,
I
we can
worked,
definitely.
I copied it on my laptop and I pasted it on my phone, and I was like praying it works. It
Yeah.
did.
So Herman and Wallace has a great directory filled with some very highly qualified pelvic floor practitioners. Then you also have a great one by the American Physical Therapy Association. Their Pelvic Health Academy. They have a great directory. And then another awesome one is the Global Pelvic Health um, wait, GPHAM. And I can't remember the exact acronym off the top of my head right now, but GPHAM, they have a great directory as well, filled with practitioners, and this is nationwide. So you'll be able to find people in your area that can, that can see you locally.
Perfect.
Mm-hmm.
And we can also share those in our the links in our bio tomorrow as
Yes.
well. And I saw Dr. Taiba Ahmed, which reminds me that there are other professionals that you
Yes.
most often collaborate with, and I
Yes.
didn't want to forget that.
Yes.
So
Yes.
thank
Thank
you
you.
for
Thank you. Thank
coming on
you.
and reminding us.
Yes. And let me tell you, more times than not, you are going to find that you're working with a team. It's very rare that I work alone, when it comes to the patients who have this condition or many other pelvic floor conditions. And when I say alone, I don't mean that they're in the session with you. What I mean is that they will usually, hi,
Hi.
they'll usually, they will usually be, we'll be talking to each other to be able to figure out how to best get you where we need you to, get with regard to this condition. And so oftentimes from the physical therapy standpoint, I'll be doing the rehabilitative part, getting the muscles to respond the way we want them to, as well as other things. But we may need to refer you back to your physician. And if you don't have a physician, refer you to one. And we may need them to look at certain testing to see if some other things are going on, or we may need them to write a prescription for some medication that could be appropriate. Typically with this area of the body, I'll typically collaborate with vulvovaginal specialists, urogynecologists, traditional gynecologists, and urologists. It's because I think that what happens is this area in the general gynecological realm that it kind of gets overlooked sometimes. So it's usually those specialists. They usually have a little bit more specific information and specific training that gets them to be able to diagnose your condition and get you to the appropriate practitioner, such as myself. In addition to that, we'll also collaborate with behavioral specialists. And that could be a psychotherapist or a sexual therapist. And a lot of times that's very helpful, because if we're ignoring that emotional component, we could be missing a huge piece of the puzzle.
Absolutely. Like, I don't think we can separate the mind out from the body and vice versa. It's a very complex situation that you're dealing with, and a holistic approach sounds like it's the best way to go.
Exactly.
Before we jump into how folks can reach out to you, I remembered that you had some props with you. And since you were talking about the home program, I remembered that. So did you want to show samples of what you had in terms of treatment?
Yes. So one of the reasons why we wanted to show this is because some people get really frightened. They were told by their physician, go get these dilators and start using them. But they're like, what am I supposed to do with them? And what is this? This looks scary. So I just want to kind of like calm your nerves and help you understand it's nothing to be afraid of. So one common tool or set of tools that we'll find are dilators. So I'm trying to put this where you can see it. This is just a small set of dilators. This is the size 1 through 4 in a set of 8. And this particular brand is Intimate Rose. And I'm not promoting any particular brand. This is just what I have on hand because, pelvic therapists have things like this in their house. So, and so this would be like the start to this set. And what we usually do is we will show the patient how to use something like this in clinic, and then we'll have them translate that over to doing this at home. And so we usually, when you're using dilators, you're going to usually put lubricant over the dilator and use that to incrementally progress the dilator into the canal. You will likely not get through one dilator at the first try. You probably may get only this much into the canal, but that's success, okay? And then what I do is teach them how to appropriately progress from one size to the next. So that's one type of tool and a common one that's used for vaginismus, right? Then you have wands. So when someone is progressing, they're doing well, we begin to see that the opening is a lot more receptive. Well, they may need some tools that they can use at home to touch the tissues that are on the side walls or that are deeper. And so a wand example I have, again, another Intimate Rose wand. This is an example of a wand. And don't be frightened. You don't have to put this whole thing into your canal. It's just for ergonomics. And so you would insert this into the canal and try to find spots that are tight and use them to release those tight muscles. And you would know that based on what you and your physical therapist did in session. You would say, oh, I remember my therapist told me to focus on this section of the canal or the side of the canal. So that's another tool. And this is just another example. This is a TheraWand. Same kind of tool, different company, different style. Okay. And another thing I may end up recommending that people use is for pain with deeper penetration into the canal. Once they've gotten even further along and they're starting to be able to try intercourse and they are still noticing it's a little tighter in the back of the canal, they can use something like this. This is called the O-Nut. And basically, there are multiple rings. And what you do is you would place this on your partner or on your sexual device, and you would use this to control the amount of depth into the canal. So this can be very helpful so that someone can have successful penetrative intercourse without a whole lot of pain in that deeper canal.
I appreciate you showing those. I know one person commented when you pulled out the dilators, it's scary, and I completely understand that feeling when for some folks looking at a tampon
Yeah.
is scary enough. And
Yeah.
then we're talking about penis, and now we're talking about these objects. So I think for everyone to breathe and know that you're not doing this by yourself. You're
No.
not buying these, getting some lube and going up to your bed and doing this. This
No.
is part of a program that you are working with your pelvic floor physical therapist, other professionals, and it is something that is under your control. So
Yes.
it's not something that is just done for the
Right.
sake of doing it. It's not a procedure.
No, not at
And
all.
so, yeah.
I'm glad you said that, because that's exactly what I hear when someone comes in and they've already purchased the set. They're like, this looks
Mm,
scary. I don't know what I can do. Now, let
yeah.
me tell you this. We don't even have to touch dilators. We don't even have to use dilators. There are other techniques and things we can do as well. This is just the type of option. We have a whole toolbox of things we could try and do. This is just one option. And again, it's only for when you're ready for it. So again, your physical therapist would usually gauge if you're ready for it. And they'll say, I think it's time that you consider this. And if you want to purchase it, you can. And then they'll show you how to use it. And you don't have to go through them fast. You will, I promise you, you will not be getting through those dilators in 1 or 2 tries. It takes a
Mm-hmm.
long time, and you have to be patient. One fact that I wanted to mention was patients often, they will just come to the sessions and then they won't do the homework.
Yeah.
I often tell them, you have to do your homework. It's a team approach. I'm a part of your team.
Yes.
You're a part of the team. So if you do your stuff and I do mine, I think we're going to have a successful outcome. So you have to do it, because you're not with me all day. I'm not going to your house all day, every day.
Mm-hmm.
That means that your muscles are going to respond by going back to where they're comfortable. So you got to maintain.
Right.
You got to keep things, where we place them, basically.
Yes, almost like training any part of your body or
Mm-hmm.
exercising. It's slow and gradual. There are days where you feel great about it, days where you're like, my body just needs a break and I need to
Exactly.
slow down. And it's not linear. And
No.
so it's a team approach. Like you're working with your PT, you're in this together, and it is something that you will hopefully make progress with.
That's 100% true. And I like that you said that it's not linear. There are going to be ebbs and flows with
Hmm.
progression and healing. There'll be times where you may say, you know what, I'm stuck on this 4th dilator. I can't seem to get to the 5th one. I don't know what's going on. Sometimes that's just where your body is at that point in time. There could be more emotional stressors, more physical stressors in your life. Things
Hmm.
could change with your job, or you may have a busier schedule where you're not able to do your home program as much. There's a lot of different reasons. So just know that as a physical therapist, I expect that there's constant progression, but it doesn't mean it's going to be zipping to the finish line. You're going to probably have time where you find that you're, dipping down a little bit into those valleys, and then you'll have those peaks in care. So just don't get too down on yourself or think it's not
Hmm.
working. It's just that's how the human body works. It does not succumb to our will. It definitely
Yes.
has to be coaxed. I often tell my patients that you got to sweet talk it. You got to sweet talk your body
Hmm.
so that it can respond the way you want it to. And sometimes it just doesn't feel like it.
Right.
Mm-hmm.
And that's okay because there's always tomorrow and the day
Yes,
after. And it's okay to sometimes give yourself a break as well and just
exactly.
mentally be in a good place.
Yes, I've had a lot of patients who we've gotten to a point and they just needed a little break from therapy, because
Hmm.
usually by the time they come to me, they've seen a lot of different healthcare providers for this condition, because people don't know that they can get treatment for it. So by the time they get to a physical therapist, they may be all wiped out. And so
Mm,
they'll start and then they need a little break before they continue.
right.
Mm-hmm.
So looking at the time, we have about 6 minutes left, and
Okay.
there are a couple questions from what were sent in that we received that I think would be great if you don't mind addressing
No,
those,
that's
and then we'll end off with you giving your information.
okay.
A lot of people ask and wonder, is having sex for the first time supposed to hurt?
Mm-hmm.
And so how would you answer that?
So, and I think we hit on it a little bit earlier when we talked
Mm-hmm.
about the hymen, but Basically, that's an interesting question. It's going to vary from person to person. Quite honestly, there's no one answer for that. But typically speaking, most people, I would say the vast majority of people are going to say that their first sexual encounter with penetrative intercourse was painful, but it should not be excruciatingly painful. Usually the terms that I hear are deep pressure, intense pressure, and then once the hymen is pierced, if it's still intact, or once that muscle, the entrance to the vaginal canal is relaxed, then usually it becomes more pleasant. So it will typically be uncomfortable, but it should not stay uncomfortable.
So it can range perhaps from being having some discomfort, having a bit of, you said deeper pain can be there. It can be uncomfortable, it can be painful. So it just depends on, like you said, the hymen, and also if there is lubrication being used,
Yes.
or
Yes. Oh, and I'm glad you said that. So when your body is naturally lubricated, it's going to be a lot easier for the penis to go into the canal. But if you're not aroused enough, then the tissues will be drier, and that contributes to pain as well. So usually there has to be some arousal involved. So that's also a big thing with the first sexual encounter. If you're not familiar with your body, or you're not really understanding what should happen, that could be that period of arousal was not long enough for you too.
So all of those factors, and understandably, someone having sex for the first time, there's a lot of nerves involved and a lot of other emotions. So just for someone to keep track of how much pain they're having after that time, if it's something that they should see somebody about.
Right, exactly. If after your first encounter you're still having pain every time, then yes, you definitely want to seek out a pelvic health professional.
Perfect. And then I think you touched upon this. When somebody, for example, has achieved their goal, the question is, do I have to keep using my stuff, my dilators, and all of this work? Do I keep doing it?
So good. That's a great question. Usually you're going to probably be doing some level of maintenance, and that will vary from person to person. It doesn't mean you're going to have to do your dilators every day for the rest of your life, or your breathing, or your stretches. It just means that, like any other muscle of the body, if I stop, for instance, let's use the hamstring. When hamstrings are tight, we stretch them and they get longer and they feel better. But if I stop stretching my hamstring, all of a sudden that muscle is going to tighten right back up. Same thing with the pelvic floor. If you totally stop having, like if you were able to eventually successfully have intercourse, and then you stopped having intercourse, and then you also stopped using your dilators, and you stopped stretching and stopped breathing, those muscles will probably tighten up again, just because that's where your muscles learn to be, and to rest. So that is your body's norm. But once you introduce those techniques again, usually we find that those tissues will begin to respond well and stretch again.
Perfect. So there might be some sort of after program as well for maintenance purposes, and to keep things kind of where they were at.
Exactly. And you'll trial and error and see what that time frame looks for you. It might be that you have to revisit it once a month. It may be that you don't have to revisit it for 3 months. It just all depends on you as an individual and what your body has now learned to do.
Perfect. So I got the countdown reminder that we have 1.5 minutes left. I love that it's there, but it's also making me really stressed.
Right.
So I did see a question about partners being involved in the PT program and using dilators. And the person who asked, I think if that's okay, Dr. Qualls can maybe DM you if that's okay.
Yeah,
okay.
Definitely.
Perfect. I'll make a note of it. And so did you want to tell folks how to reach you for direct message and for services? And I'll paste it if this works too.
Definitely. So you can actually visit the website at www.qualitypt.com. You can also call our office at 301-246-2353. And you can email me at dr.q@qualitytouchpt.com. That's dr.q @qualitytouchpt.com. And I'm also on major social media platforms.
Yes, and so we pasted the information below. Thanks to Instagram, we only have 30 seconds left. So Dr. Qualls, I really can't thank you enough for sharing your expertise in such a practical and understandable way. So I know everyone is grateful. I was reading the comments that people were nodding and agreeing with you. So thank you so much for spending your Wednesday evening with us. I really, truly appreciate you.
Thank you for having me.
Absolutely. Awesome. Well, if you have any other questions, direct message us, and then hopefully we'll work on some educational posts. Please follow Dr. Qualls. She has a lot of great information already. And everyone stay safe and have a great night. We're going to shut off in 3